Hi, welcome to Law and Justice. I'm Jane Mulcahy. This is a special series on the topic of relationships matter, and today I am so looking forward to chatting to Dr. Ruth Lanius. Hi, Ruth, how are you?
Hi, Jane. Thanks so much for inviting me. It's a real honor to be here.
Yeah, I'm so excited because we met in person in Belfast at the Trauma Summit last year and had a good chat then.
I so enjoyed your questions at the Action Trauma Summit. So I look forward to, furthering our conversation.
Super. So before we kind of get into the topic of particularly dissociation, because you're such an expert in that, maybe you can tell me just a bit about yourself to get started, Ruth, please.
Absolutely. So I would say I'm a passionate clinician and researcher working in the field of trauma. And I've always learned from the individuals I work with, and they've really taught me, most of the things I know. And I've been able to really take that knowledge I've learned from the first person perspective of traumatized individuals and then applied that to the research questions my group has asked. And so when I first became interested in trauma, when I did my internship, I had actually signed up for neuropathology, so to specialize in neuropathology.
Wow.
And as part of that, I had to do a general internship. And the first month was psychiatry. And I was working on an inpatient unit, mostly with traumatized women who weren't labeled as that. They had all sorts of different psychiatric diagnoses. But talking to them, I quickly learned that the root of their difficulties was trauma. And so I had a wonderful month working there. And I thought to myself, I think I've made a mistake in this
Okay.
specialty I've chosen. And so I had a mentor who I approached about changing my specialty, and he facilitated that. And he was also a neuroimager. And so, this field was very new at the time. It was really exciting to actually start learning, what happens in the brain in individuals who are suffering from different mental and emotional difficulties. And so I had the opportunity not just to work with individuals who are suffering from trauma, but also at the same time, make that invisible injury more visible. And so, I switched over to psychiatry, and I started doing clinical and research work. And I've been on that path ever since.
Thank you, Ruth, for that great introduction to yourself and your fascinating work. So in many of these previous podcasts, I talk to people about the importance of safety and attachment. So maybe we can have a bit of a discussion about that too, from your experience as both a psychiatrist and in the research field. How important is it to have this kind of felt sense of safety and a positive, secure attachment experience in infancy? And if we don't have them, does that then have a negative impact maybe on how we function and experience ourselves in the world and experience other people?
Absolutely. That felt experience of safety in infancy, I think, sets up how we view ourselves and the world later on. And so I think it's an absolutely critical experience. And when you have a secure base, right, when you have a secure attachment relationship, you learn what safety is. You really learn the experience of safe sensations, right? Because that's what you get from the caregiver, right? Safe visual input, but also visual input that mirrors the infant. And, auditory input that's safe, the cooing of the mother, right? The nourishing taste of the milk, right? The gentle touch. And I think that's so critical in helping actually the individual start to know where they begin and where they end.
Right.
right? And when we talk to our traumatized individuals, especially those with severe early developmental trauma, they often don't feel like they have a boundary around themselves, right? They don't know where they begin and where they end. And so they don't know what emotions are theirs and what emotions are the emotions of someone else.
Okay.
And then, of course, we also have the rocking, right? The balance system that I think is so under-focused in trauma. A foundational system that helps us to perceive our inner and our outer world, right? And really shapes that. And so, yeah, all these safe sensations that we experience as a result of a secure attachment relationship really start to form and shape how we see our inside world and our outside world. And when this is safe, right, when we learn that there's safety from the attachment relationship, you know, we start to feel safe sensations inside. Our inner world feels safe. And of course, the way our inner world is shaped really determines how we perceive our outer world.
Yeah.
Right. And so if I perceive my inner world as safe, you know, I'm going to be much more likely to feel like the world is a safe place, that I can trust others, and that it's okay to connect with others. But this is, of course, very different when we don't have that secure base, right? When we don't have a secure attachment relationship. And, you know, the trajectory is that we get unsafe sensory input, right? You know, our caregiver may have an angry face or may not be present, right? Because of their own difficulties. And this is not blaming anybody in any way, right? This always has a reason, right? But, you know, we keep seeing an angry face that we don't feel safe with, or a face that's not there. That's terrifying, because as mammals, we rely on a caregiver, right, for survival. And if we don't have enough gentle touch, right, our sense of self is going to develop very differently. And if we don't have adequate stimulation of the balance system, we're not going to feel a safe grounding to the earth, right? Because that's one of the major functions of the balance system, right?
Yeah,
is
fascinating.
To help, right, feel grounded and safe on this earth, to have that center of balance, right? And of course, our traumatized clients don't have that, right? They don't feel safely rooted and grounded to the earth. And so when you don't feel safely grounded or rooted to the earth, you can't protect yourself, right? You don't feel safe, and you become vulnerable. And your internal world is unsafe, right? And when your internal world is unsafe, you're very likely to see the external world as unsafe, which is how you grew up in, right? And so the external world is unsafe. You can't trust people. And that makes connecting with others very, very difficult. And we know the importance of connection, right? Connection is what helps us regulate under stress, what helps us feel a sense of belonging. And we know it's the most important predictor after a trauma, right? Just to predict whether we're going to get sick or not. But if we have that history of not having that safe attachment, connection becomes unsafe many times. And so I think that's one of the critical things to overcome in the aftermath of trauma, to really be able to orient to safe sensations, you know, because they haven't been available from a safe attachment relationship, and from being able to orient to safe sensations, creating a safer inner world, which will allow us to view the world as safe and really connect with others and use that absolute critical resource.
Thank you, Ruth. That's beautifully explained, and makes a lot of sense to me now. Although as a mom, I might not have known all of that. And I feel in a way that perhaps many people in the general public don't have access to all this information. Now, maybe they can read books, but they mightn't realize just how critical the serve and return reactions are, or, for example, mobile phones, and how we can all become a bit dissociated and fall into them and then not be very attuned to what's going on. And then there's a bit of a backlash at times to attachment theory, and the fact that a lot of it seems to fall at the mom's feet. But of course, dads can be attachment figures as well. Isn't that right?
Absolutely. Yeah.
Yes.
And really anyone, right? And I think we see this with, our traumatized clients. If they've had one safe relationship, and, even if mom was really sick and couldn't take care of the infant and the child, and dad was absent, but there was, a safe aunt or a safe family friend. We see this clinically, right? That makes all the difference.
Mm-hmm.
Right? I think our most complex patients are the ones who tell us, I have never felt safe with anyone, right?
Yeah.
So that's so critical, right, to really find out about when we get to know the clients we work with.
Yes. And so maybe we'll move on and talk a little bit about trauma itself, what it is and maybe what it isn't, because there are many definitions. And even just the other day, I heard people saying they were traumatized over this or that, and they were just banding the word around. But even within the field, there isn't always crystal clarity about what is meant, whether it's huge events like warfare or sexual violence, or the phrase psychological trauma appears to be being used a lot. And I just wonder, does that adequately capture the fact that so many of the symptoms actually are in the body as well, and in the sensory system? So do you have a preferred definition or description yourself, Ruth?
Yeah, I think that's a great question and a very complex question. And of course, we have the official definition in the DSM, the criterion A, you have to have experienced extreme threat or horror, and your life has to have been a threat to experience post-traumatic stress. And that's sort of the official definition. But we know that, for example, neglect, right, it has some of the most profound effects on somebody's emotional stability and emotional difficulties. And neglect and withdrawal from the caregiver, can lead to dissociation, depression, substance use, eating disturbances, you name it. And Carlin Lyons Ruth has outlined this very well. And of course, that per se wouldn't officially classify as a traumatic event. And so I think we just have to get really nuanced in describing, what the person experienced and what the trajectory as a result of this experience has been. We don't have, I think, a good definition overall. And so I think, we really have to understand, what does this individual experience? And I think here the sensory system is really important. And trauma and neglect and emotional abuse, which also wouldn't classify as a criterion A trauma, right? And this is why I think a lot of clinicians refer to big T versus little t traumas. But all these different traumas are really insults to the senses. And I think if we take a sensory perspective of trauma, then it makes more sense. So, of course, the big T traumas are insults to the senses, but neglect is a significant insult to the senses. Emotional abuse is a significant insult to the senses. And we now have a really good understanding of, when these sensory inputs are unsafe, what happens to the mind, brain, and body. And I think this can really help bridge, the definitional problems we have, but help us explain the symptoms by really understanding what happens in brain, mind, and body
Yeah.
after different types of big T and little t traumas. Does that make sense to you?
Yeah, it does, but possibly only because of having, read a bit and done various trauma trainings myself. And for example, Stephen Porges, who developed the polyvagal theory, I did some training with him, and he was saying that he would view, say, things like mental health issues and addictions as neural state disorders, so that it's to do with the state of our nervous system being kind of dysregulated, and over time as well, not just generally a one-off. How then does dissociation play into this? What even is dissociation for people who maybe don't know what it is?
Yeah, so dissociation, I think simply put, is a psychological and bodily escape.
Okay.
When no physical escape is possible, right? So when we're stuck in a situation of inescapable trauma or inescapable stress, our brain, mind, and body have to figure out a way to escape when no physical escape is possible. And the brain, mind, and body are brilliant at doing this. And so, dissociation at the time of the trauma is incredibly adaptive. It's in the aftermath of trauma that it can sometimes interfere with daily life and starts to really bother people. But at the time of the trauma, it's incredibly adaptive. So, for example, if somebody is being repeatedly assaulted, often they detach from their own body, right? And so the sensory input from the body no longer reaches the higher levels of the brain where we know what we feel. So
Okay.
no longer know what we feel. We've disconnected from our body. And when our body gets repeatedly hurt, this really works, right? It's an incredibly adaptive strategy. And this can sometimes get to the point when the trauma is really repetitive that the person no longer feels like it's their body.
Yeah, wow.
Right? So I think that's when we have a lot of identity dissociation, like we see in the complex dissociative disorders. And I have a client who describes this very beautifully. She saw herself as being in the tree, and the body, which no longer felt like hers, was on the ground. And she was able to have empathy for that body. But the spirit and everything else was in the tree with her.
Okay.
So incredibly protective. But now when you get to the aftermath of trauma, and you can't experience sensory input from your body, you can't experience your body, you start not to be able to feel any emotions, positive or negative, right? You feel numbed out, you feel detached. And as Jeanne taught us, often you feel that you're not really alive anymore. And so it's really learning to reawaken the capacity to feel those emotions again, and those sensory feelings in the body, those visceral feelings in the body, to reconnect with your body, to re-inhabit your body. So this is one example of dissociation. Another example of dissociation is, of course, being pulled into flashbacks.
Okay.
Right? Being pulled into the past and having limited ability to know that you're in the present, or you lose that ability altogether. And for example, if we think about our veterans, right, in a grocery store, say one of our veterans goes to the grocery store, there's noise, they get triggered, they may become extremely irritable and then actually hide. So take the position they had, when they were in combat, in theater, and hide somewhere, right? So they flashed back to the original trauma and lost connection with the present. That's another form of dissociation.
Which must be so frightening.
Oh,
To be feeling the past in the present and feeling it with the same sensations as at that time? Would that be common, that the very, very same terror of that moment would be felt?
Absolutely. And I think that's one of the critical things that we now know, is that traumatic memory is actually not remembered, but it's relived. And it's relived in the body with all those visceral sensations. And we actually just published a paper showing that, in brain images, how the sensory and motor network becomes coupled with the back part of the memory network that has no context, the part of the memory network that relives. And so it becomes coupled with the sensory motor network. So we're reliving in the body. It's essentially, we always knew, from Bessel van der Kolk and Babette Rothschild and others, that, the body keeps the score, the body remembers, but this gives us insight into how the body remembers.
Yeah.
And can really guide how we, intervene with trauma on a sensory and motor level as well.
It also, I guess, kind of shows that the post part of post-traumatic stress disorder might be slightly inaccurate, in the sense that it is ongoing almost, or that the person can be hijacked at any time maybe, and they may not even put the trigger or whatever activated them to what they're then feeling. They mightn't be conscious of that link. Is that true as well?
Absolutely, because when you're dealing with these unsafe sensations, only the survival brain, the reptilian brain, so very low within the brainstem, even below the amygdala, that part of the brain reacts without thinking. You don't have time to think, right? Thinking is part of our higher brain, the cortex, but we don't have time to think, right? We have to react without thinking. And so that part of the brain becomes dominant. And, the higher part of the brain, where we think, where we speak, where we have a sense of agency, that gives us a sense of time, and where we can consciously connect with others and really know what the other person is feeling and what their intentions are. That part of the brain is not optimally engaged. And so, we react without thinking, where, this lower part of the brain becomes dominant, and that's how we survive, right?
Yeah. And I'm just thinking as well, that some of the people that I've come across now, I'm not a clinician, and my research kind of only touches on this every now and then. But some people that I've met in person and online have said things like, there are years of my childhood or my teens that I don't remember. Is that suggestive that something might have been going on for them at the time, that there was this separation, or is it usual that people could have very long gaps in their memory, Ruth?
I'm so glad you bring that up, Jane. And that's another form of dissociation, right? And that's called amnesia.
Okay.
And, when we get clients who tell us, yeah, there's huge chunks of my childhood I don't remember, or my memory is really like Swiss cheese, right? It is, again, their mind, brain, body protecting them, right, from the pain. And I really want to clarify here, and I think this is something I think we really need to think about and study more. It's not that they have lost those memories, but what's happening is that the brain networks that help us to verbalize those memories are not fully connected. So often those memories are remembered in the form of sensations in the body, right? And this is a key thing, I think, to become aware of when we get to know a traumatized individual. How big of gaps do they have in their memory? Because if they have extensive gaps, they're more likely to suffer from complex dissociative disorders and problems.
Okay, thank you, Ruth. And so then, for someone who is a trauma survivor, who might find it very difficult to feel safe around anyone, really, including a therapist, And they might just find it so hard to trust because they've never been able to do it before for good reason. So what then can therapists actually do, or other helping professionals, let's say in the criminal justice system where someone is put on probation because they've had addiction and committed crime to feed the addiction. What can people do to build a positive relationship with them? Because without a positive relationship, it's going to be very hard to do any work on the other issues.
Which is such another critical issue, right? And I think the first step is awareness. We often think, oh, we're therapists, right? And we try to help people. And I think we don't realize how terrifying we can be to a traumatized individual, right? Because they were often hurt at the hands of caregivers. And of course, we're caregivers.
Yeah.
And so we're a huge trigger. So I think it's so important for us to be aware of it, but then also bring it up right away. What's it like for you to be in the office with a caregiver, with me, right? Given that you've had very negative experiences with caregivers, what's that like? And what do you need to feel safer? And this is where I learned a lot during the COVID-19 pandemic when we were doing online treatment. And, it didn't work for all, but I saw for a significant proportion of my patients that the online treatment decreased their hypervigilance.
Wow.
Because home, often with an animal on their couch in their safe place, and then engage in therapy from that safer place.
Fascinating.
Right? They didn't have to go out in the world. They didn't have to sit in my office and have me as a caregiver, which is a trigger, right, next to them. And so I really learned, and I was astounded by the fact of how much deep trauma work I was able to do with people during the pandemic. Now, this didn't work for all,
Yeah, but it's good to know that it's not the one size fits all as well.
Exactly. And it never is, of course. Yeah. Right? And then others really lack that connection, right? They really, needed some of that personal connection. But it was really interesting to see that. And so I think we have to dose it, like everything in trauma treatment, everything needs to be dosed very carefully, right? And so we need to discuss how difficult it may be to be in the same room. And then we can work with, distance between the two of us. Would it feel safer if you moved further away from me? Would it feel safer if I closed my eyes? Would it feel safer if you sat close to the door so you can escape, right? And then really getting the person very slowly to orient to safe sensations, because that's something they don't know often, right? And, we have to really reprogram the brain and body, right? And that takes time. And that always reminds me of a statement from Richard Clough, who said, the slower you go, the faster you go.
Okay.
Right? Because when you're suffering so much, I mean, you just want to get rid of it, right? You just want to move on, even though moving on is also terrifying at the same time. But you want to get rid of that suffering, but you got to go at a pace that your brain and body can tolerate. So I think that dosing is absolutely critical.
That's really interesting about the slowness and kind of not rushing to get it all out. If you've decided I'm going to trust Ruth, I'm going to tell her everything. Can it be as well that people kind of not re-traumatize themselves, but get really, really activated by talking about it, and that can be kind of maybe counterproductive at times?
Absolutely. So when you work with somebody, they always need to be in the window of tolerance, right? If they have too much arousal, too much emotion, or too little arousal and too little emotion, they can't process any information, right? Processing shuts down.
Yeah.
So you got to stay within that window of tolerance, and to really teach individuals that, and teach them how to recognize that within their body. Oh, these are signs that I'm moving outside the window of tolerance. So, what can I do to bring myself back into that window of tolerance? I think is absolutely critical. And yeah, for the therapist to watch for that, but also for the individual to really start to become more aware of that.
And so then there are lots of therapeutic modalities out there. So, for example, in the criminal justice area that I do my research in, for a long time, cognitive behavioural therapy type approaches, the top-down, cortical brain type of interventions have been the most popular. But from various reading and training I've done, I know that sometimes the body-based somatic approaches can be good for, again, greater nervous system awareness, or maybe combining aspects of various modalities. Are there ones that you find particularly useful in your therapeutic work, Ruth?
Absolutely. And I think, you bring up all the core questions, Jane. This is really the art and the science of trauma treatment. How do we optimally combine top-down and bottom-up treatments, right? We all use cognitive treatments. We're human, right? That's how we think. That's how we negotiate the world. But we also live in a very disembodied world, right? And I think we're still suffering Descartes' error, right?
Yeah.
I think, therefore I am. It's really, I feel, therefore I am. And so I think we're underutilizing the bottom-up treatments, that focus on the sensations, on the movements, and the visceral feelings. And I think it's really critical to think about this, especially because we now have lots of data that the cortex, where cognitive behavioral therapy really has its target. I mean, it targets directly the cortex. It's not optimally online. And so I think through these bottom-up treatments, right, through helping the body settle, feel safe, feeling safe internal sensations, that creates an environment of safety, which will then help the cortex come online optimally. And so it's all about what treatment to do, where and when.
Okay.
And, unfortunately, the bottom-up treatments haven't had a lot of research. So I think it's really an urgent priority to have research for these treatments. We live in an evidence-based world. We need evidence. And so I think it's really an urgent priority to research those treatments. And they would include, sensory motor psychotherapy, somatic experiencing, there's many others. Neurofeedback is also a treatment, and we have some evidence now that can really intervene at these deep brain levels and change these visceral sensations. Deep brain reorienting that was developed by Frank Corrigan is another such treatment. We just are doing a randomized controlled trial with very promising interim results. Again, this treatment targets directly the lower parts of the survival brain that really deal with these visceral sensations and these bodily feelings that are critical in the aftermath of trauma, and that can drive so much distress, and that can have an profound effect on how we view ourselves and the world.
Thank you, Ruth. I did actually a one-day training with Frank in Cork before the pandemic, and it was really interesting to see it, and not a whole pile of language used. Again, it's not very verbal. I mean, there are some instructions, but interesting, and as you say, going inward and focusing on the internal experience and the sensations. In relation to the work that I'm doing at the moment, the research work, which is to support a gang intervention or a couple of gang interventions in Ireland. So the young people, many of them have histories of extreme adversity and trauma, as do their families, or so it appears. And then they live in communities where there's a lot of violence and disruption and poverty. And what we're finding in one of the trial sites where they're providing a type of therapy, functional family therapy, is that for some of the young people and their families, they're not as ready for it. And it appears that there is a link between attachment problems maybe and past and ongoing trauma that makes it more difficult. Is that something that you might have observed in the past, Ruth, that if people have attachment histories that have been damaging or destructive, and they're still living through trauma, that'll get in the way of actually doing therapeutic work?
Absolutely. I mean, if you're still in the trauma, it's much more difficult to heal, right?
Okay.
But it's not impossible. But the first goal needs to be to slowly shift the individual out of the unsafe situation.
Okay.
But here, I think we really have to think about that a lot of traumatized individuals only feel alive under threat.
Wow.
And we now have the neurobiology to show that as well. So I think that's one factor that keeps individuals in these unsafe sensations. And shame, right? I'm bad. I'm not deserving of anything good, right? And so again, here, this is really something to think about. How can we intervene bottom up, right? Because we can't talk people into, getting out of these environments, right? They have to almost feel themselves out of them. Right? And this is, I think, where Liz Warner's treatment really comes in, and providing individuals with different forms of sensory equipment so they can find what sensory input they need to feel safer. And what I've noticed when individuals are provided with different pieces of equipment, this could be, for example, a sensory swing or a rocking chair or, a trampoline or, what we call a yogi board, where somebody can lie down or sit down and feel really held and supported, that these different forms of sensory input can really change the emotion regulation difficulties an individual has, and eventually really allow them to connect better. And so starting to provide individuals with safe sensory input in the context of a relationship, of course, right? A safe relationship also, of course, involves safe sensory input. But then if you can use some of this equipment, I think it can really facilitate individuals moving towards safety over time. This is no quick fix, but see this, on the videos. When I watch Liz Warner's videos, it can be really profound. And I think we need to think about this. We need to think about it in schools. Now so many traumatized kids who can't sit in a chair, right? A lot of our clients, the children, can't sit in a chair during therapy. In the probational system, right? It's full of traumatized individuals. So how can we start intervening from a bottom-up level where they can have these safe sensory inputs in the context of safe relationships, and then slowly move towards feeling safer inside, which will help them to feel more embodied and less likely to engage in these, really unsafe behaviors, which is often a way of feeling somewhat alive and feeling really semblance of having a body because they have no other way.
Yeah, it's so interesting because one of the goals of any criminal justice program is to kind of often make people think about their victims, but also reduce impulsivity without understanding that half the time people aren't choosing to be reckless or impulsive. As you say, they can be driven unconsciously into these unsafe situations. But as you were talking about Liz's work there, it sounds like an awful lot of occupational therapy style approaches are being. Is she an occupational therapist or a psychiatrist, Ruth?
She's a psychologist, and she's
Okay.
worked with occupational therapists. She has added, a couple of key things. One is really the focus on the relationship in conjunction with these different sensory inputs, and then also doing part two. So as the individual is able to tolerate safe sensory input and seek safe sensory input, often, they start to talk about their trauma because the brain networks start to connect that help us to have a trauma narrative. So then the
Wow.
trauma is online, and those higher brain networks of connection start to come online. And so you see how all of a sudden, these individuals can start to talk about what happened to them and be connected at the same time. It's really beautiful to watch. And, as a neurobiologist and really interested in the brain, I can actually see how some of the brain areas that we keep seeing as being offline are starting to come online as individuals are engaging in this treatment.
So exciting, all right, for sure, to see that, and as well, to be able to map it out in the research for people to kind of not just presume that the brain and body, are quite separate still, but actually that it's a whole, and working in a more holistic way with people and following a sequence of engagement maybe might have more productive outcomes, at least for some people.
Absolutely. And, we know that all these pathways start in the body, and they go into the survival brain where they can have a significant effect on arousal and raw affect or raw emotion. And then they travel all the way up to the higher levels of the brain, right? Mm-hmm. And so another intervention is deep pressure, right? We know how calming deep pressure can be. Mm-hmm. That's why we have weighted blankets, weighted vests. And again, it's a beautiful example of body-brain connection, right? Intervene on a body level has an effect on how aroused we are, what raw emotions we feel, and how we can think and connect. Touch is another one, right? We all know that, gentle, soothing touch at a time of distress, especially when you haven't been traumatized, sometimes it can be a huge trigger for traumatized individuals. Sure. But generally, gentle, compassionate touch at a time where we feel in turmoil can be incredibly soothing, right? Yeah. And it's just, that's another, beautiful example of how the brain, body, and mind are connected. Right.
Yeah, it is phenomenal. And, certainly I and my kids and my family would be quite tactile. And I've spoken to some other people on the podcast about the touch taboo in therapy and in the helping professions, really, probably because of the power dynamic and how maybe things were abused in the past. But it can be appropriate, can't it, Ruth, at times to put a hand on someone if they're giving a signal, I guess, that would be welcome, or is it still a difficult area for therapists?
I think you have to be very careful with boundaries as a therapist, right? And, I wouldn't recommend touch in general unless you're, trained in touch, and unless, you're a somatic therapist and, be trained in it. But I think, we can really encourage our clients to start receiving safe touch from the people around them. Right?
Okay.
With them and the people around them. And make touch a real priority in treatment. That way. Does that make sense?
It does, because boundaries are, of course, as you say, very important, and to preserve the safety and the containment of the room and not be blurring things. So that does make sense. How appropriate would it be for other helping professionals, to, for example, I know some people have said, "Oh, give me a hug." If someone asks for one, let's say from a youth worker, can that be appropriate, or do you think that it's risky in that context as well?
You've got to be careful, we're all human, right? And sometimes putting your hand on somebody's shoulder if they long for that. But I think also to ask them, how can I hug you with words?
Right.
Right. And then, having groups, in a group, individuals can, I think, ask for hugs and start working with boundaries very well. Right. And really experiment, what feels safe, how close the person coming into my space feels safe, how far away do they have to be to feel safe. Right. And I think that's, where the somatic groups can be very helpful. Right.
Yeah.
And I think there we can really preserve boundaries.
Thanks. It is a question that does come up sometimes, and I know that there are certain types of body modalities, and massage and various things can be quite healing. But I suppose having the safety around it for people is so important. Can I ask you one question, Ruth, about drug use, trauma, and the value of psychedelic-assisted psychotherapy for working with trauma survivors, including maybe people with dissociation? Is that something that you're interested in yourself?
Absolutely. And it's something we're exploring. And I think the psychedelics provide another tool, right? I'm all about integrative approaches to trauma treatment, right? And I think one of the key things to treat individuals successfully is to have as many tools or ways of therapy available that you can. And so I've gotten training in many of these different therapies, including CBT, psychodynamic psychotherapy, DBR, sensory motor, EMDR, ego state work, neurofeedback, you name it.
Nice.
And psychedelics, are another important tool in our toolkit. And I've seen a number of individuals really shift significantly after psychedelic treatment, where they were able to develop more self-compassion towards a certain part of the self and really experience positive emotion more fully and tolerate positive emotion more fully. But I want to warn against a couple of things.
Sure.
One, we're now thinking psychedelics will be the next magic cure, right? Because of course, what we'd all like, right? I don't think that's the case,
right.
Especially when somebody has been traumatized repeatedly and, during critical developmental periods, it's a course of recovery, right? It's a long path of recovery. Can psychedelics help? Yes, absolutely. Also, this really needs to be done in a safe therapeutic environment. And things are going to come up, right? As with any form of treatment, things come up, emotions come up, thoughts come up, sometimes deep visceral sensations come up, and the individual needs help to make meaning of those things. And so I think you really need that therapeutic relationship as a safe container to then process those things and also achieve, the maximum benefit.
Yeah. So it's not then a case of it being equally therapeutic for a bunch of young people to take MDMA or ecstasy at a rave, or ketamine or LSD, but not have someone there who's highly skilled and trained to hold them should something challenging come up for them.
That's what I would say, yes. Yeah.
Yeah. Okay, thanks, Ruth. I just have one more question for you, and I so enjoyed our conversation. It's been fascinating. I always kind of end with this one because I am very interested in the decision-making process and public policy and what politicians choose to do with our scarce resources. So what, in your view, can they do to kind of increase the likelihood that all children will enjoy a safe, healthy, connected childhood and grow up to be able to reach their full potential?
Which, of course, is the key question, right? And I think this is where early intervention comes in, right? Intervention to mums and dads that are at higher risk, right? And I think this needs to start during pregnancy. And really, we need to help those individuals really feel safe with parenting and, know more what they feel and how their own inner world and outer world, affects the child, really teaching them about how the mother-child and caregiver-child relationship, again, not to exclude dad is equally important, has a profound effect on the development of brain, mind, and body, and how, we have a number of studies now that are showing that this early intervention can have profound effects years later and really decrease the emotional suffering of those kids. So I think early intervention is absolutely key. And I think this really needs to be pushed with the policymakers. It's more difficult because politicians like to see effects immediately, right? Mm-hmm. And these effects will be years down the road. But this is how we're going to make our society safer, how to reduce, mental and physical difficulties and suffering, as well as how to decrease violence. So I think it's absolutely critical to have this early intervention. We have more studies now, and to really push the policymakers for this. And I think the other priority needs to be to get more research for the bottom-up treatments, mm-hmm. so we can optimally combine bottom-up and top-down treatments to reach all those individuals who don't do well with the mainstream treatments, which is a significant proportion of individuals. But I think there's a lot of hope here. I think the data are starting to emerge. And so I think it'll be critical that we take this to the policymakers.
Thank you so much, Ruth. I've had a ball with you, and you've been so generous with your time. This has been Relationships Matter with me, Jane Mulcahy, and the wonderful Dr. Ruth Lanius. Thanks again, Ruth.
Thank you so much for having me, Jane. I always love talking to you. So I hope we get a chance again in the future.
Yes, we will. I'm sure, and hopefully we'll meet again, maybe in Belfast or elsewhere. And I look forward to the updates on your brilliant work. Thanks, Ruth.
Thank you, and I look forward to speaking again.